Back with our public investment proposal plan for the community mental health systems improvement through public-private partnerships. That probably is private-public partnerships, I think is what you meant. And we are thrilled that all of you are here. Thank you for taking time. You will have 7 minutes, and then we'll have 7 minutes for questions. I just wanted to give a quick shout out. We have some council members who are with us as well. Councilman Russ Pulley is here, and we appreciate his attendance. I also wanted to say that we have lots of PIP requests, and even if I appreciate all the hard work that you all have already put into this, hopefully we'll be able to move forward with this one. But if this doesn't go forward this year, it doesn't mean that it's not a great idea. It doesn't mean that there's not an opportunity for it. It may mean it needs to be fleshed out a little bit, or we may need to wait a little bit. So thank you for your time. And Dr. Paul, I'll let you kick us off.
Thank you, Mayor. The clock is running. I will introduce everyone at the end. We're glad to have the members of the PIP team here with us, many of them who have been really supportive. I'm Dr. Bill Paul from the Health Department. I'm here to talk about reducing criminalization of mental illness in Nashville. Let me ask you a question. If your family member had appendicitis, would you take them to jail or to an emergency room? If your family member had a mental health crisis, where would you take them? Not to jail. But as a community, we are too often sending our people to jail with mental health crisis. On any given night, there are 300 people with serious mental illness in Nashville's jail. The jail population is decreasing, but the number of mentally ill is not. Jail is not a therapeutic environment. The criminal justice system is not designed to treat mental illness. A criminal record can damage a person's life, impact their housing, their employment. It's expensive, it's not healthy, and it's not right. Our system of mental health care in the community is fragmented and underfunded. When TennCare pulled back in 2005, many people lost coverage completely. Our Nashville is now growing, but our mental health services are not. Our community needs a better system. Jail has become a default, and we're getting too comfortable with that. Now is the time for change. Thank you, Mayor Berry, for asking for this PIP. We've got several elected officials who've been engaged in change. Also, Healthy Nashville, Vanderbilt, St. Thomas Health have identified mental health as a strategic health priority for Nashville. We've got a number of community partners and advocates, many of them here, who are saying that now is the time for change. The time for commitment and action is here. Diversion is a word we use a lot in this field. It's a good thing. We want to divert patients away from jail and towards care in the community. The best thing is treatment in a community setting and never getting arrested in the first place. If a person is arrested, there are many levels at which we can do diversion, and those are all good. And we already have some of those in place, and all of those would be part of a complete community plan. But all of those need community services in place, and those resources are lacking. As we gathered with the mental health PIP team, we wondered where to start. This is a big and complicated animal. As a starting point, we identified several areas that we think we should pay attention to in the next 3 years, 3 that we're pitching to you right now. This is a start. The project will be bigger than what we're able to pitch to you right now. Our early focus is on these 3 things. Number 1, closing gaps in our 24/7 mental health urgent care system. Number 2, developing a planning council for Nashville for mental health. Number 3, prioritizing prevention and addressing adverse childhood experiences. I'm going to talk about each of these 3 in a little bit more detail. For our 24/7 mental health urgent care system, we want the right care at the right time in the right setting. There are 2 key organizations involved with this, the Mental Health Co-op and Nashville General Hospital. Mental Health Co-op already plays a big role in our 24/7 urgent care system. We're proposing to add 2 dimensions to their work. Number 1, 24/7 medical on site. This allows them to use their facility more fully. It allows them to reduce the number of patients that are transferred to emergency room for medical care that could be cared for on site. Second, security at the Mental Health Co-op, so that if police are bringing people to the co-op, they don't have to stick around and wait for the whole time that a person's being assessed and treated at the co-op. Nashville General Hospital, in your PIP, you see them asking for a capital budget, but ultimately they're going to use their existing resources to reconfigure in the emergency room to take better care of mental health patients. We are asking for a 24/7 crisis counselor from the co-op to be at Nashville General to expedite transitions of patients to offsite and other facilities. For the Planning Council, this would be a group that will monitor and improve health services, mental health services in our community. We will work around a common agenda, shared measurement, mutually reinforcing activities, and continuous communication. We're asking in this PIP for support at the Health Department to be the convener, the facilitator, and the support for this Planning Council. As far as the data support goes, that would be provided by the Health Department. Finally, prevention. We think it's important to keep our eye on prevention in the long run. You've heard a lot about adverse childhood experiences, their impact on long-term health and mental health and quality of life. A lot of these patients started their life with many adverse childhood experiences. I think our care system will be better if we are always both training and changing our systems to be conscious of the impact of ACEs. We'll be data-driven and evidence-based. Here are some of the things we'd be measuring in year one. More people treated and stabilized at the co-op, lower wait times at the co-op and at Nashville General, more efficient use of police resources if police are diverting patients from other places and using these community settings for care. Years 2 and 3, we will be building diversion at more levels and ultimately fewer mentally ill people in jail. In the long run, we must work together to build up our community mental health system so people with mental illness can live stable lives and not be forced into criminal justice model to manage a medical condition. Again, this proposal is the start. I really want to acknowledge this team that came together on a very short notice, collaborated in good faith, and expressed a real commitment to making change. And thank you, Mayor, for your leadership on this issue. Thank you for your attention.
You've got 51 seconds. You can introduce him if you want.
Oh, I can. Dr. Joe Webb from Nashville General Hospital. Judge Melissa Blackburn. Amanda Brock from the Mental Health Co-op. Angie Thompson from my staff. Sam Scales from Elam. Okay. Dawn Diener, the Public Defender. Damian Huggins from the Police Department. Bob Vero from Centerstone. And Will Connolly from the Homelessness Commission.
Great. Thank you so much.
I still got 24 seconds.
You do. You can enlighten me with 20 more
really
seconds.
I really think that the time for change is now, Mayor, and I will keep talking until my time is up.
You mentioned at the beginning that currently in our jail there are 300 people on any given night that are mentally ill. So what are going to be my cost savings to going toward this model where I'm going to reduce the number of people in the jail, therefore saving me on my jail costs?
Right. That's a tough thing to calculate because it's sort of like the marginal cost of a person in jail. If they're not in jail, you don't necessarily recoup that one for each fewer patient. But yes, right now we're spending, I think, $900,000 of our $13 million correctional health contract just on the mental health piece, and it's not how we would do mental health. So we would expect to have some savings on the correctional side, both on the correctional health side and potentially on the sheriff's side of things, if we're successful with this.
Questions from the panel?
Yes. This seems to me to be a diversion program, which is good, crisis intervention, but it seems that it doesn't address the long-term needs. So if the mental illness is schizophrenia or bipolar, or these are not things that are necessarily addressed in childhood training or intervention with
Right. So there is a big gap in basic provision of mental health care in the community,
right,
as well as case management. And those are things that as a group we would want to get a better sense of what are the assets we have, what are the needs before we came with a large request for funds on that.
Are you saying that this planning group would address the gap that exists in long-term care care of these patients. We can,
right, absolutely.
We can build something that keeps them out of jail that night.
Right.
But recidivism and long-term health care need to be addressed.
Right. So there are many pieces to this, and we chose 3 to start with, and they were really ones kind of at that junction of the decision point of crisis, and does this person need to go to jail, or is there another place? And so we recognize as a team that what we were presenting was not a complete solution to the problem, that long-term follow-up care is important, but as a planning council, that is something that we would address moving forward.
I know.
Thank you.
I agree.
I like the concept of what you're triaging. Have you looked at, based on the data you already know, once you triage, where's the likely places folks would go and what % wouldn't really have a place to go after triage? It's sort of a different question than Nancy's, but complementary, I think, because that's, I very much am a fan of what you're trying to do here, but once we triage someone and we know they have a serious illness that needs help, do we have any stats on what they do after you triage them, where they go?
I'm going to see if Amanda might have an answer to that from the Mental Health Co-op, because they're dealing with patients in crisis.
What volume you expect per day,
Sure.
what % goes where, what % just simply has to go back to where they were because there is nothing for them.
Sure. I can tell you right now, about 40% of the people that the current crisis system sees end up being referred to inpatient care. So they're ending up at Middle Tennessee Mental Health Institute or Vanderbilt or one of the other psychiatric facilities.
Okay.
Now, of the rest of those individuals that don't, I can't break it down into detail, but there are, as I think may have been in the proposal, we do have some programs at the co-op that are short-term stabilization. You're looking at 2 to 3 days with the goal of linking them to the longer-term services. In terms of what happens after that 2 to 3 day stay, we don't have accurate data right now. How many of those individuals are homeless? I can tell you that there's a pretty large percentage of those.
I would imagine.
And the resources for individuals with serious mental illness who have needs in our community that they don't have the financial resources for housing, that is one of the barriers, and that's something that we discussed as a planning group.
Okay. And these additional 11 FTEs, how many more individuals will we be triaging day to day, week to week, on top of what we triage today?
I think we estimated about a 25% increase, and that's just based on the growth we've seen over the last several years. We've seen, I believe over the last 4 years, we've seen about a 31% increase in the overall volume that our crisis team is serving.
I would imagine.
Are those individuals, 2,500 individuals coming in, or 2,500 visits?
Visits. Those could be some repeat individuals. Okay. Absolutely.
Okay.
You mentioned that you want 6 to 8 beds, I think, as a part of the build-out.
So was that for General Hospital? Yeah. So one of the things I was speaking a little fast. General Hospital, the plan is not within this kit to ask for funds for the build-up. General Hospital, and that's a change from the
I see.
If the General Hospital has resources to do that reconfiguration, and that's going to be, we'd be happy to use those funds to build other parts of the system, but it's not needed for the capital expense at General.
And was that originally included in the cost projection here? So is that a number I can take down?
Yes.
Yes, you can take that up. Actually, we have an inherent responsibility there, and in order to move our patients through the ED, once they come in crisis, what we've been having to do is to get RNs to take care of them. What we're going to do is use our own resources just to modify some rooms so that we can utilize mental health technicians that will sit with the patients and then expedite the stabilization of that population so that they can be more expedited in their disposition to the appropriate setting for care. So we didn't need any capital to do that. We can take care of that.
Maybe I can throw in one faster. It may be one better for Damon than someone else, but in the interaction between the police department and this triaging, for an individual who continuously is cycling back in, which there are, what happens beyond the 2-day sort of crisis intervention, because I'm sure it gets a frustration for the individual, for the folks triaging, for the police department, everyone, and I'm just, I know that's a real chronic problem, so just trying to see how this might address some of that.
And that's another good question. That's nothing unique to today in today's discussion.
Right.
The police department pays a lot of attention to those people that come in and out of the system that we use resources on, and have tracked a lot of data and cost benefit. And over about 3 years of us addressing our top chronic offenders, we've seen about $1 million in cost benefit analysis that includes resource savings, which doesn't go away if we add FTEs. It's still police officers that have to be paid. Right. But in conjunction with that, in this discussion, Judge Blackburn has looked at the most chronic offenders that we see in Nashville and is working on a program through the drug courts to address those people that continually re-enter the programs as behaviors don't change, so that they get diverted instead of just re-arrested going through the revolving door. So that's kind of a byproduct of these discussions that I think is very advantageous.
Thank you. Thank you.
Thank you. Thank you so much. Thanks to all of you all for coming down here and for the great thought that went into this. I really appreciate it.